Hello, this is Dr. Tran from VietMD.net, a non-profit medical organization in the US dedicated to help Vietnamese patients and doctors. Today we have our special guest again, Dr. Kashyap Patel.
Thank you for having me here.
In evidence-based medicine cases with VietMD.net. In this series of EBM, we're using cases from EBM.com from Stanford University School of Medicine in California. Basically, those are cases compiled from the professor over there. So in this case, we talk about gout, come from Dr. Bush. So Dr. Patel, can you tell us a little bit about gout and what is your experience with gout?
So gout is one of the most common causes of arthritis that you see in the clinic. So it's something that we should all be familiar with diagnosing and comfortable treating in the clinic.
So let's start with a case here. We have a 52-year-old Filipino man come to your office. He presented with 2-day history of severe right knee pain.
Okay.
And he said that his pain began suddenly, okay? And it keep increasing in terms of severities. The patient denied any trauma or any history of recent arthritis or pain. He's taking hydrochlorothiazide 25 milligrams each day for his hypertension. And his doctor just recently started a baby aspirin each morning. This patient, however, he had 5 years episode of renal insufficiencies, and he drank a couple of beers over the weekend. You think that's a good idea?
Of course. This patient has all of the risk factors for having gout. This is the most classic presentation that you would see. Not everybody will have all of these things, but some things to think about in a patient. Firstly, the severity of the pain is usually very, very severe. And it can be debilitating. It can prevent patient from being able to ambulate, making them bedridden, for instance.
So you mentioned about age and genders, right? So those are the risk factors that increase for this patient having gout. How about race? Is there any, when you compare races between?
Yeah, so this is fairly prominent all over the world, but particularly this gentleman being of Filipino origin is also putting him at risk. Filipino Pacific Islanders are at above average risk for having gout. But again, this is one of the more common arthritis that you'll see. So you'll see it in every race of patients that you have. As far as the age goes, usually you'll see it in the older population, 50s to 60 years old. However, sometimes people as young as in their 20s sometimes can present with gout. It's not uncommon.
Interesting. How about his history of renal insufficiency? Does it bring any more risk?
It definitely elevates risk. So if you go back to the pathophysiology of gout, what you see under the microscope when you examine the synovial fluid of the joint is monosodium urate crystals that are strongly negatively birefringent.
Sure.
So where are these crystals coming from? It's theorized that this is from hyperuricemia, from overproduction of the uric acid, from xanthine oxidase, which is the enzyme that is critical in the production of the uric acid crystals, or uric acid in general, before it crystallizes. So 90% of the patients with gout, or roughly thereabouts, will have some sort of history of renal insufficiency, either overproduction of uric acid or under excretion of uric acid. Both of these will increase your total body stores of uric acid, thereby increasing your risk of developing gout and possibly tophi.
Interesting. That's very interesting. Now, when we mention about diagnostic tool and what are the keys to establish a diagnosis of gout, what would you recommend?
So gout is one of those diagnoses that are made clinically mostly. patient comes in with, as we discussed, the severity of the pain. Oftentimes it's monoarticular, especially patients in their first episode of gout will have involvement of just one joint. During the subsequent flare-ups, they may have 2 or more joints. But usually mono or oligoarticular joints are involved. Oftentimes there's erythema and significant swelling and, of course, tenderness on palpation. And some of the bigger joints, such as knees, which is less commonly involved in the foot, but the bigger joints may have effusion as well. So again, clinically made diagnoses, also taking into consideration their social history, as we discussed in our patient,
Sure.
he's consuming alcohol, taking a look at their medication history, specifically diuretics, which is one of the more commonly prescribed class of drugs. Hydrochlorothiazide causes a decreased excretion of uric acid. So one of the things that you want to look for. Ultimately, gout is, the diagnosis is initially suspected clinically, but it's confirmed with analysis of the synovial fluid.
Okay.
So arthrocentesis is necessary.
So you recommend aspirate fluid from the need?
Absolutely. You definitely want to confirm the diagnosis of gout, especially because this diagnosis carries the prognosis of potential further exacerbations. The patient may or may not require maintenance therapy down the road as well. And these therapies, of course, like anything in medicine, has side effects. So a clear diagnosis of gout would definitely serve the patient well.
Sure. So just mention one key thing about synovial fluid. So what are the key findings? Just tell us very briefly about what the key finding when you look for.
Yes. So the diagnosis of gout depends on finding those uric acid crystals. They're usually strongly negatively birefringent, needle-shaped objects under the microscope, as opposed to, for instance, positively weakly birefringent crystals that you'd see in calcium pyrophosphate disease.
That's a great idea and great discussion about how to make diagnosis. Now let's move to treatment, right?
Sure.
So we just discussed about gout diagnosis in our patients. Now let's talk about treatment for these gentlemen. Well, in case of gout exacerbation, so seems like we have mainly 3 option treatment for gout, right?
Yeah.
The first one is NSAIDs, I'm sure you know this. The second one is steroid, and the last one is colchicine. Now, when gout exacerbation, can you tell us pro and cons in each class?
So the NSAIDs are the most readily used class of drugs. Of course, GI bleeding is one of the risk factors that you should consider as one of the contraindications that you should consider in a patient. Also, severe renal insufficiency is another one, as the NSAIDs can exacerbate this.
Sure.
As far as steroids go, the main contraindication being, relative contraindication being uncontrolled diabetes and the concern for hyperglycemia, in addition to the myriad of other side effects that steroids have. Typically, both of these are actually equally effective. In fact, a study by men found this to be the case. However, there were differences in terms of the adverse effects for the two. GI bleeding being higher in the NSAID-treated group, of course.
And the last thing about colchicine.
Colchicine, yes. So it's also one of the more effective medications. It was, unfortunately, the trial that studied colchicine compared colchicine to placebo rather than colchicine to any other medications. So we know that it works. We don't know how well it works compared to prednisone or NSAIDs, for instance, however.
Okay. So in acute gout exacerbation, your main 3 options are NSAIDs, steroid, and colchicines. And as Dr. Patel just mentioned, you use based on the clinical indication and individualized based on your patient's care. Now, what would you recommend in terms of chronically manage the patient with gout? What would you do?
So that depends on the frequency of exacerbations, the severity of the flare-up, how debilitating it is to the patient. Consideration can be made for starting the patient on medications to reduce the serum uric acid. Again, this being the hypothesis that the higher uric acid level contributes to formation of these crystals within the synovial space, which in turn leads to flare-ups with inflammation.
I see.
So the main classes of drugs you have are the more commonly used xanthine oxidase inhibitors, allopurinol being the prototype of that class. There's also another one called febuxostat, which is much more expensive, being a newer medication.
Sure, it's very expensive.
Hopefully we won't have to find out.
Sure.
Maybe you will have gout of your, yourself. And
we will talk about that in the last section when we compare the two. So when you talk about chronically, those are medication to maintain or manage gout chronically. Well, so let's move on and review a couple of articles in terms of treatment of gout, and we go from there. You see, we talk about diagnosis and treatment of gout in acute gout exacerbation and chronically managed gout. In these last sections, we talk about review evidence-based medicine, review articles in terms of gout. So let's just remind about what is evidence-based medicine we discussed in the previous sections. So basically, usually we start with a clinical question first, right? So when you see patient, your question is, what are the guidelines? What are the current evidence? Then you start looking for evidence. And once you're looking for, you appraise that evidence. You see that is that strong, is that good evidence? Or this is like somebody just put online, right?
Right.
And then you Google it.
yeah.
So once you're looking for evidence and you found one and you found a good one, then you're going to apply that to your clinical practice. And the last step is you continue to monitor to see that help or not, because if that works, keep working. If not, then you look for another evidence base. In gout, we're going to review 3 articles today. The first one I'd like to discuss with you is from Dr. Becker's. This study published in New England Journal of Medicine in 2005. And basically, this is a clinical trial to compare febuxostat versus allopurinol. So in this randomized double-blind study, they given 2 doses of febuxostat, 80 and 120 milligrams. They versus allopurinol, 300 milligrams daily. And they followed those patients for 1 year. And those patients, they already confirmed with gout, and they also based on uric acid level greater than 8 milligram per deciliter. So this study has 760 patients, so that gives you a good number of patients to start with. And they randomized, they even divide between 2 groups. And the result basically for febuxostat, the larger dose, 120 milligrams, is actually associated with a higher rate of gout attack. Interestingly, in the first 8 weeks, compared to 80 milligrams of the febuxostat. However, starting from week 9 to week 52, which is the last part of the year, there's no difference in terms of incidence of gout flares. And between the two, the rates of discontinuation of the study drugs were higher in the febuxostat groups when it's compared to allopurinol. Now, so what are some limitations of this study that you'd like to tell us?
Yeah, so this study actually looked at doses of febuxostat which were a little bit higher than what are actually available for prescription here. They looked at the dose of 80 milligrams versus 120 milligrams versus allopurinol. Of course, the higher dose febuxostat was a little bit more effective in terms of reducing the uric acid level in the serum. However, this dose is actually not available for prescribing. The ones that are available are 40 milligrams and 80 milligrams. So you're making the assumption here that 40 milligrams will be effective as allopurinol will be based on this study. but we don't necessarily know that. We don't have the data for that from this study.
I see. Now, in this study, they also excluded patients with moderate to severe renal insufficiency.
Yeah, and that's a strong point because the main advantage of febuxostat is over allopurinol is that it's mostly hepatically metabolized. So the idea is that you could give it to patients who have renal insufficiency without needing specific dose adjustments, as opposed to allopurinol, which does require dose adjustments. However, the patients with moderate to severe renal insufficiency were not studied in this. Were not included in the study, so we don't know. We don't have the data to prove that it's as effective and it's as safe as allopurinol is.
I see. One of the disadvantages actually of febuxostat when compared to allopurinol is pricing, right?
Yeah, that's a big part.
Realistically, is that very expensive?
I have no idea what the numbers are, but I'm sure that it's very expensive.
Yes, actually it's very expensive and it's very from state to state in the US, but like you, Dr. Patel say, it is very expensive. So if the patient have a kidney problems and they have money, then you recommend febuxostat. That's the bottom line, right?
Yeah, febuxostat is definitely effective in terms of lowering that uric acid level more than allopurinol is. Again, the rates of gout flare-up are similar at 1 year. They're both equally effective in the long-term setting.
So if the patient does not have any other medical problems, then the two of them are equally effective. And of course, you would like to go with allopurinol because it's much cheaper and it's more affordable to a patient. So the next study we would like to review is actually from Dr. Mans, and this is coming from the Annal of Emergency Medicine publication in 2007. So in this study, they compare PO oral steroid, and they compare oral steroid versus oral NSAIDs with acute gout.
So this was also a double-blinded study that looked at oral corticosteroid versus oral NSAIDs. The NSAID that was studied was indomethacin, which is typically used for gout because it's one of the more potent NSAIDs. This was indomethacin 50 milligrams 3 times a day for 2 days, and then a slightly lower dose of 25 milligrams 3 times a day for 3 days. So a total of 5 days of coverage with indomethacin. And the steroid arm received 30 milligrams of prednisone for 5 days. So same duration of therapy, a little bit step down of a dose in terms of indomethacin midway into the therapy. And both of these had similar improvement rates at resolution of symptoms at 14 days.
That's very interesting. Now, as any study, you like to look up limitations with this study. One of the first limitations, when I look at it, they mentioned there's 90 patients. So would you think that's a number is small?
No, yes. So it's not clearly not a big study. When you're when you're designing a study, you have to look at the power that's required to separate two groups. So the power required to separate, say one group is not the same as, statistically not the same as another group, based on, that'll be affected based on how many patients you have in your group, the N of the study basically.
When you compare this study to the previous study we just mentioned, which has 760 patients, this one has only 90 patients. And also another limitation for this one, I don't think they follow a patient after, right?
This was, yeah, the limitation was that they were reassessed at 14 days, and we don't know what exactly happened to these patients afterwards.
Exactly. So, but again, this had happened in the emergency room, and they like to see the efficacy or effectiveness of the medication in the acute gout or exacerbation, and probably that's why they do this.
Yeah, the other thing to mention is that the gout in these patients was a presumptive diagnosis. As we talked about in the beginning, Gout has a lot of clinical characteristics that make you suspicious of the disease, but the way to confirm it is with arthrocentesis. These patients did not necessarily undergo this arthrocentesis to confirm that they had uric acid crystals.
Sure. So the bottom line is simply oral steroid versus oral NSAIDs are equally effective.
Equally effective. So I guess you would have to look at the contraindications that the patient has and the side effect profile of the drug you're considering to see which one is a better fit for your patient.
Sure. So the last study we would like to talk about, actually it's a very interesting study here. This study done by Dr. Kashyap. This basically this study they compare colchicine. Oral colchicine is a very common medication for gout, but in this study they compare low dose versus high dose. And this study has been published recently in the Arthritis Rheumatology in 2010s. And so can you tell us about this study a little bit and why they compare low versus high dose?
Again, the risk and benefit ratio is what we're looking at, like with any other drug. Oftentimes patients do receive these high-dose colchicine with the thought that it's maybe more effective. But contrary to that, this study actually found similar response to the medication. There was no statistical significant difference in terms of pain response in the low-dose group versus the high-dose. The low dose being colchicine 1.8 milligrams over about an hour, high dose being 4.8 milligrams over 6 hours. So effectiveness was similar, but the side effect rate was different. GI side effects, namely diarrhea and vomiting, they were about twice as more common in the high dose colchicine group versus the low dose group.
Very interesting. So the bottom line, if you have a chance or give an option between the two doses, you would like to go with a low dose, and this confirmed by clinical trials. So in those three studies, we like to mention, because that shows you the beauty of evidence-based medicines. Before those studies coming out, actually people thinking or doing things that they think makes sense, such as in this case, a lot of people will think that high dose colchicine will be better than low dose.
Correct.
And in some cases, actually, you see that people think steroid would be the best. Actually, they just want to give steroid.
Yes.
And when you compare steroid with NSAID, you don't see a difference. And the last one, go back to our first study, brand name drug like yes, sometimes not the best, even though they're expensive, they are brand name. But the equally effective, the basic drug has been there for years, which is allopurinol. So I hope this case and this discussion give you some update about gout treatments and give you some idea about evidence-based medicine. And we continue to make a series more of cases in other topics. And if you have any question, you can contact me and we can discuss more in the future. Before we finish, any other recommendation for our audience?
No, I think we covered all of the details. Basically, evaluate the side effect profile of the drug you're considering. That's going to be the main choice, main way to decide which medication is appropriate for a patient. And again, reviewing the evidence and specifically the limitation of the evidence in helping you make a decision on whether or not this drug actually is as efficacious and is as safe as we think it is.
Sure. Thank you very much. And so after this discussion, hopefully all of you become gout champion, right? Let's get rid of gout. Thank you very much.